I'm going to get started. Welcome, New Orleans. I'll be down there next week for the AUR. So today I'm going to talk about pediatric chest radiology. We'll start with the newborn, the normal appearances of the thymus, the TTN, transient tachypnea in the newborn, the most common cause of respiratory stress in a full-term newborn, Meconium aspiration, hyaline membrane disease, which is now called surfactant deficiency disorder, and between that it was called respiratory distress syndrome, pulmonary interstitial emphysema, bronchopulmonary dysplasia, now called chronic lung disease of prematurity. So the normal appearances of the thymus, children are especially little babies and infants and young children, they have thymuses. We all have thymuses, but they have big ones. And it can be the sale sign. We have two sale signs that we use. The anterior fat pad in the elbow is a sale sign, which is abnormal. The anterior fat pad itself is normal, but if it's a sale sign, it's abnormal. Posterior fat pads of the elbow are always abnormal. But in the chest, the sale sign is the thymus. It can be symmetrical, bilateral, or asymmetrical, or unilateral. On the lateral view, the opacity in the retrosternal space is the thymus. Normally in an adult and a teenager, this is nice and black, and this is nice and black. It should get darker as it goes down. If it's white down here, we worry there's a lung process, a mass, pneumonia, pleural effusion, hemorrhage, something's going on down here, and the same thing is in here. This on an adult or a teenager or an older kid, this should be nice and dark because of the lung. But in a younger child and an infant, this is the thymus. Here, if this was you and I, we have a mediastinal mass. But here is an asymmetric opacity on the right. This is just an asymmetric thymus. Here we have the straight margin. Straight margin is almost a sale sign, but this is the thymus. If this is you and I, we have a mediastinal mass. Here is a very asymmetric thymus, but this is part of the thymus as well. And here it looks like there's a mediastinal mass in this kid, but this was a rounded thymus. So you just got to realize what the thymus can look like. Transient tachypnea of the newborn, like I said, is the most common cause of respiratory distress in the full term. It's due to failure to absorb the fetal lung fluid produced by the lung epithelium. These patients will have normal to increased lung volumes. It will look like they're in pulmonary edema. There'll be pleural effusions. There'll be fluid in the lungs and the interstitium. And like I said, it's usually full-term infants. They'll have tachypnea and increased oxygen requirements present during the first few hours of life. It's called transient because within 24 to 72 hours, it should go away. If it does not go away in 24 to 72 hours, we have to worry about neonatal pneumonia because that can look identical. Causes is increase in C-section babies. They used to think it was because they were passing through the birth canal and that squeezed the chest, but now they know that labor causes increased epinephrine, and epinephrine inhibits the chloride pump, which secretes lung fluid, and epinephrine stimulates the sodium channels to absorb the lung fluid. So there's so many elective C-sections nowadays that the woman never goes through labor at all, and so the epinephrine never gets increased, and so these babies are increased risk of getting TTN. Maternal asthma or smoking may possibly be a cause as well. But this is probably the biggest reason. This is one reason for sure, but this is probably the bigger reason, the lack of going through active labor. Here's a case of transient tachypnea in the newborn. You can see a pleural effusion. You can see the pulmonary edema. This looks like the patient's going through pulmonary edema, which this is, the shagginess in the parahilar regions. Here's another case. It's pulmonary edema. You see a little bit of fluid in the fissure. You don't see the big pleural effusion, but see a little bit of fluid in the fissure. This was transient tachypnea in the newborn. Meconium aspiration. The lungs will be hyperinflated, and they're going to be patchy or streaky infiltrates with some atelectasis. There could be pleural effusions. Just like in transient tachypnea in the newborn, that has pleural effusions. Surfactant deficiency disorder does not have pleural effusions, but meconium aspiration can have pleural effusions. They can also get pneumomediastinum and a pneumothorax due to the hyperinflation and the air trapping from the meconium. It actually causes a chemical pneumonitis as well as a bacterial pneumonia. Here is a case, there's a patchy infiltrate here, there's patchy right upper lobe infiltrate, there's fluid in the fissure, and there's a patchy infiltrate down here. This was a baby that had meconium aspiration. Respiratory distress syndrome or surfactant deficiency disorder, we see it every single day in the NICU. These babies lack surfactant, which is produced by the type 2 nematocytes at about 24 to 28 weeks, and then it will gradually increase until full term. So the younger the gestational age, the more likely they're going to have surfactant deficiency disorder, the more likely it'll be worse, and also the less weight of the baby. Incidence, 35 to 36 weeks gestation, about 5% can have it, up to 65% at 29 to 30 weeks. It says Caucasians more than African Americans, but every baby can have it. Male to female is 2 to 1, but both sexes definitely get it. They used to call it hyaline membrane disease, and that's because the damage to the alveoli and the desquamation of the lung cells and the exudative necrosis and the protein leakage caused hyaline membranes. So that's why they call it hyaline membrane disease. But now they know that you can have meconium aspiration cause hyaline membranes, severe pulmonary edema can cause hyaline membranes, hemorrhage can cause hyaline membranes, and so can pneumonia. That's why they got rid of hyaline membrane disease and changed it to respiratory distress syndrome. And then they changed it recently to surfactant deficiency disorder because that's exactly what it is. The chest X-ray will show a diffuse reticular granular or little nodular pattern throughout the lung fields. They may have a ground glass appearance, and this is due to microatelectasis. The lung volumes will be low unless they're on CPAP or intubated. So initially the lung volumes are low. In transient tachypnea of the newborn, the lung volumes are normal to increased. In meconium aspiration, they're hyperinflated. In RDS, surfactant deficiency disorder, they are low. They have to give them high dose oxygen. That's to oxygenate the alveoli that are open to make the baby live. We know that high dose oxygen is toxic to our lungs. It also can cause blindness in the babies. High dose oxygen is toxic. But if they don't get this high dose oxygen, the babies are going to die. They give them surfactant, and that's to keep the alveoli that are open. And whenever the new ones open, then to keep them open too. They give them high positive index expiratory pressure. They put them on CPAP, and that's to try to open up the collapsed ones. But initially, the granular lung pattern is due to microatelectasis. Then later on, they're going to get pulmonary edema. Here we have a granular, it looks like I got a piece of clay and just broke it up, punches tiny little dots all through these lungs. This is a patient with RDS, surfactant deficiency disorder. This is not the minor fissure, this is a scratch on the actual film. This was a film. Here's an ET tube. We have an umbilical artery catheter. We have an umbilical venous catheter. If you cut the cord, there should be a 3-vessel cord. There should be 2 arteries and 1 vein. If you can't remember how many arteries, how many veins, just remember that the umbilical artery at the belly button loops down into the iliac artery, and then it goes in the aorta. And you know that the aorta bifurcates into 2 iliac arteries, so if there are 2 iliac arteries, there have to be 2 umbilical arteries. The umbilical vein goes straight up into the umbilical vein, goes to the left portal vein, skips the left portal vein, goes to the ductus venosus, into the inferior vena cava, then into the right atrium. So there's only 1 umbilical vein. You'd like the umbilical vein to be near the inferior vena cava right atrial juncture, down here near the hemidiaphragm. You'd like the UAC to be at about T6 level, T6, T7. And so a lot of times the umbilical vein is in the right atrium, that's too high. Sometimes it's in the region of the liver, that's too low. Pulmonary interstitial emphysema, any kid that's on ventilation can get it. It's especially common in preemies that have surfactant deficiency disorder. That you will get small oval to rounded lucencies in the parahilar regions, which may progress into larger cystic areas that could resemble congenital lobar emphysema, which I'll show you in a minute. And this can, of course, lead to pneumothorax. This is air in the interstitium. Here you see all these little black little circles, little tiny black little round circles that are really prominent in this area. This is bilateral pulmonary interstitial emphysema. Bronchopulmonary dysplasia, now called chronic lung disease of prematurity, is in any infant that has been on high dose oxygen for a month. That's usually what we say, 28, 30 days. That's bronchopulmonary dysplasia. That is scarring of the lungs. The kid will always have some scarring. When they get bigger, the patient's going to get better. But this is due to oxygen toxicity. It can be due to trauma from the mechanical ventilation, but they're usually the prematurity ones. Those are the ones that need the high dose oxygen, and the surfactant deficiency disorder and a PDA are causes. But the main cause is the oxygen toxicity from the prematurity that these babies have to have. These chest X-rays, the lungs are going to have increased lung volume. There's going to be big cystic areas that can enlarge with irregular coarsened interstitial linear markings. If severe, you're going to have a big heart because there's pulmonary arterial hypertension, core pulmonale, and then death can occur. There's a thing called Wilson-Micody syndrome. These are premature infants who develop respiratory distress after a week after birth. The chest X-ray shows bilateral cystic areas that look just like BPD, but it was too early. It was too early. It wasn't a month like BPD is. So this was after about a week. And these changes can slowly resolve over months if the infant survives. It's called Wilson-Micody syndrome. Here is an example. These are much bigger than the PIE was, and this baby is over 30 days. You have coarsened lung markings, increased lung volumes. There's the PDA clip, patent ductus arteriosus clip. We have big cystic spaces all throughout, especially the lung bases. This is bronchopulmonary dysplasia or chronic lung disease of prematurity. Congenital conditions that you will see, the big ones are now they're under the headings of bronchopulmonary foregut malformations. This includes your bronchogenic cysts, your pulmonary sequestrations, your congenital pulmonary airway malformations, your CPAM, used to be called CCAM, congenital cystic adenoma malformations. Now we call it congenital pulmonary airway malformations. Your congenital lobar emphysema, your congenital pulmonary veno-lobar syndrome with your scimitar syndrome, and your congenital diaphragmatic hernias. They're all under bronchopulmonary foregut malformations. They can be associated with each other. If you have one, you might have the other. Those are hybrid lesions. A bronchogenic cyst, the most common place for a bronchogenic cyst is in the mediastinum. Here, you can't see it very well, but there's a fullness here and there's a soft tissue fullness here. The most common place for it is subcarinal, but this is not subcarinal, but it's up in here in the mediastinum. When you find a mass, you can do an MRI to save on radiation. A lot of times they just do CT, but MRI would show you a bronchogenic cyst and there would be no radiation. Here it is right here, and it is a bronchogenic cyst. I know it doesn't show up very well because it's dark and the lungs are black. Here's a different one. Here's a fluid. It's close to the subcarinal region. It is right here. It's fluid density. It's well circumscribed. It's in the mediastinum. This is a bronchogenic cyst. About 15% can be in the lung itself, the lung parenchyma. Pulmonary sequestrations. When you have a recurrent pneumonia in the same spot, especially if it's at the left lung base or the right lung base, but especially the left, you have to worry maybe there's a pulmonary sequestration. Here, if you always look, if you get the seniors there in New Orleans, we have seniors here that are about to take the test. If they show you a case and you're looking all throughout the lungs and you don't see anything, look to where we miss things. Look up in the neck. Look, see if the trachea is being displaced. Look up at the lung apices for Pancoast tumors. Look over here in the shoulders to see if there's some bone tumor. Look in the hilar regions, parahilar regions. Look at through the diaphragm and the upper abdomen. Look behind the heart. And if you look behind the heart, you see that there's definitely a consolidation. There's an opacity here in the left lower lobe. So this one went to CT. You want to do CT with IV contrast because what we're looking for, this is that, quote, mass, close quote. But you can see from the aorta, there's a vessel that's arising from the aorta. So there's systemic arterial supply to this. So that's the sequestration. Here's the reconstruction images showing you the aorta and the pulmonary artery from the, not the pulmonary artery, the artery coming from the aorta supplying this with lung below it. So this is the intralobar or intrapulmonary sequestration with systemic arterial supply. There's two types that you have to know about of sequestrations. Both of these are congenital malformations with non-functioning lung tissue normally. There's usually no communication with the bronchial tree, and they both get systemic arterial supply. You get the intralobar or the intrapulmonary is by far the most common, up to 85%. These will be enclosed by visceral pleura. It's probably acquired, and it usually presents as an adult. Male to female is 1-to-1, as opposed to the other type, which is more common in males. I'll talk to that in a second. These are associated with congenital anomalies less than 10%. It could be skeletal anomalies, diaphragmatic, cardiac anomalies, or renal anomalies. They're going to have systemic arterial supply, but they're going to usually have pulmonary venous supply because they're intrapulmonary or intralobar, as opposed to the next one, which is the extralobar or the extrapulmonary type, which is about 15 to 25%. These are enclosed by their own pleura, called a Rokitansky lobe, and this prevents collateral air drift, so these should be an airless, rounded mass. These will start off with fluid, then they'll get mixed fluid and air, and then later on they'll be aerated. This extralobar, a developmental abnormality, this is usually going to present in the neonatal period, and male to female, 4-to-1, male more than female. This has a high association, up to 65% with congenital anomalies, especially the diaphragmatic hernia or diaphragmatic paralysis, but it can be associated with CPAM, congenital pulmonary airway malformation, lobar emphysema, total anomalous pulmonary venous return, a TE fistula, renal anomalies, vertebral anomalies. These little babies can present with congestive heart failure in the newborn due to shunting. This is much more common on the left side. This is too, and left side of the lung bases. Extra lobar or extrapulmonary gets systemic and arterial and systemic venous supply and drainage. The intrapulmonary sequestration, usually there's no communication occurring with the tracheobronchial tree. There's an elemental communication with other bronchi or lung parenchyma that may exist, allowing infection to occur. Like I said, the most common place is the posterior basal segment, and almost 2/3 of them are on the left. I said the venous drainage is usually pulmonary veins. Foregut communication is very rare, and anomalies are not that common, as opposed to the extrapulmonary, which are common. This is the majority of the sequestrations. I told you male, female equal. More than half of these will be diagnosed after adolescence. I said these are more likely to be diagnosed in the adult or the late teenage years. Symptoms in neonates and infants are uncommon, but may begin in early childhood if they have multiple episodes of pneumonia in the same spot. The extrapulmonary, which is the rarer type, is enclosed completely by its own pleura. It may occur above, below, or within the diaphragm, and they're almost always on the left. No communication with the tracheobronchial tree. There's not going to be any collateral drifts or anything, so there should be a gasless mass. Venous drainage is by the systemic venous circulation. This is common. Foregut communication associated anomalies are not uncommon. They are much more common than the other type, than in the intrapulmonary or the intralobar. Males 4-to-1 over females. I've stressed on that. More than half of the cases of extrapulmonary sequestrations are diagnosed when the patients are younger than 1 year of age. Often it's because of the other congenital anomalies they have. Maybe they have a diaphragmatic hernia and that's what presented. So remember, if you have a cardiac malformations, they're going to do a workup and that's how they might find it. It could present with recurrent lung infection. The treatment, if they're asymptomatic, they usually follow it. But if it becomes surgical resection is a treatment choice when they develop infection or symptoms resulting from compression of the normal lung tissue. The problem with the intrapulmonary type, which is the most common, and that's the one that presents usually as late teenagers or adults, is that they have to do almost a lobectomy because they don't really know where this pulmonary sequestration starts and where it stops. So they have to often do a lobectomy. As opposed to the extrapulmonary lesion, you can usually excise this without losing any normal lung tissue. Congenital pulmonary airway malformation can be anywhere in the lung, any lobe. Here we have a partially air, partially fluid, partially solid. This is right here, you can see there's some mass effect on this lung. This is a congenital pulmonary airway malformation, formerly called CCAM, congenital cystic adenomatory malformation. This is hamartomatous proliferation of glandular tissue without alveoli. There are no alveoli. Blood supply is usually from the pulmonary arteries. The sequestrations get blood supply from the systemic aorta or a systemic branch. This is usually going to get their blood supply from the pulmonary arteries. There are 3 types that you should know. Type 1 have big cysts, greater than 2 centimeters for the CPAM. Type 2 have microcysts, less than 2 centimeters, often with a solid component. And type 3 have tiny, tiny cysts that appear as a solid mass. Just like in infantile polycystic kidney disease, they have very tiny, tiny 1 to 2 millimeter cysts. So when you do an ultrasound, they're very echogenic. You don't see cysts. You see an echogenic kidney. Well, in this case, if it was a ultrasound, prenatal ultrasound, you might see a hyperechoic mass in the lung base or in one of the part of the lungs because of these microcystic changes. They surgically excise these early if symptomatic and later due to increased risk of malignant degeneration, the risk of a pneumothorax or repeated infections. The most common hybrid lesion is the type 2 congenital pulmonary malformation, airway malformation, CPAM, and the pulmonary sequestration. That's the most common type. The type 2 that have the little cyst less than 2 centimeters and a solid component, and a pulmonary sequestration. Other coexistent hybrid lesions can occur. You can have CPAM or congenital lobar emphysema with a bronchogenic cyst, or bronchial atresia, or even a tracheal bronchus. So they all kind of related to each other. Congenital lobar emphysema is here you have a very lucent lung. You would worry if this is a tension pneumothorax, but here you can't see it, but in good setting, you can see little tiny markings in here, but you have the left upper lobe is hyperinflated, it's crossing the midline, and everything is being shifted over to the right. This is congenital lobar emphysema. Congenital lobar emphysema has lobes that it loves. The left upper lobe more than the right middle lobe, more than the right upper lobe, and it hates the lower lobes. Congenital lobar emphysema is progressive lobar distension. And like I said, left upper lobe, more than right middle lobe, more than right upper lobe, hates the lower lobes. Sequestration loves the lower lobes. CPAM can be anywhere. Male to female, 3-to-1. Extralobar or extrapulmonary sequestrations, male 4-to-1. Congenital lobar emphysema, male 3-to-1. Etiology, there's theories. It could be a dysplastic versus immature bronchial cartilage that causes this. There could be endobronchial obstruction or compression that causes this, or there could just be alveolar hyperplasia that causes this. Initially, this is going to be fluid-filled, just like pretty much all lesions in the lung are going to be fluid-filled. Filled with fluid, then it becomes aerated and causes hyperinflation of the affected lobe with air trapping and compression of the remaining lobe on that side and shift of the mediastinum away from it. It's associated with congenital heart defects, especially PDA and VSD. And the treatment is surgical resection. So again, just a recap of the bronchopulmonary foregut malformations. Intralobar sequestration, 60% of the left base. Extralobar sequestration loves the left lung base at, below, or within the diaphragm. Bronchogenic cyst loves the mediastinum, 15% can be in the lung. CPAM, any lobe. Congenital lobar emphysema, left upper lobe, more than right middle lobe, more than right upper lobe, hates the lower lobe. Congenital pulmonary venolobar syndrome is this case right here. Here you can see that the heart and all the great vessels are shifted over here to the right. The left lung looks hyperinflated, the right lung looks small. We have this vessel. If you follow this vessel, it goes down below the diaphragm and then it goes into the inferior vena cava. So that's your scimitar syndrome. When you do reconstruction on it, you'll see the actual scimitar, which is this right here. So when you have a hyperlucent lung, you have to look, is the hyperlucent lung, if they're normal size hemothorax, if that lung that's blacker is normal size, it could be technique, it could be off-centering. If you look, for off-centering, you look and you'll look at the shoulder. The left shoulder might be whiter and the left lung whiter than the right shoulder, and the right lung and the right abdomen will be whiter than the left abdomen. That's off-centering. They could have had a mastectomy. When you have an adult has a mastectomy, that lung on that side is going to be more lucent. Poland syndrome is absence of the pec muscle. So if you have right-sided Poland syndrome, your right lung is going to be more hyperlucent, but it's going to be normal sized. If you have a PE, it's going to be more lucent if you have the Fleischner sign, Westermarck sign. Fleischner sign is the big pulmonary artery central to the proximal pulmonary embolus. And distal to the pulmonary embolus, you have oligemia, which is the Westermarck sign. Westermarck is the oligemia, so that's going to cause hyperlucency. Fleischner sign is the big pulmonary artery proximal to the clot. And then, of course, your Hampton's hump is the infarct peripheral, the wedge-shaped defect. If you have a decreased hemothorax and it's hyperlucent, you worry about Swire-James-McLeod syndrome, which is a complication of chronic bronchiolitis, usually a viral bronchiolitis in infants, adeno or RSV in early childhood. They actually have a decreased number of vessels with a small hilum. The congenital pulmonary venolobar syndrome, also called the hypogenetic lung, affects the right lung more than the left, and right middle lobe more than right upper lobe, more than right lower lobe, more than the left side. You're going to have a small hemothorax, decreased vascularity, and a small hilum with the mediastinum shifted towards the affected side, and that's the one that has the scimitar syndrome. A hyperlucent lung with a decreased size on that side could be a simple pneumothorax. We have a simple pneumothorax, the right hemodiaphragm elevates, the cardiomediastinal silhouette shifts to that side. That's a simple pneumothorax. If you have a hyperlucent lung and there's increased volume on that side, it could be a tension pneumothorax, which is a medical emergency. It's an emergency. You need to put a needle in the second anterior intercostal space of the midclavicular level immediately, then put a chest tube in. It could be air trapping from a foreign body or bronchial lesion, such as a carcinoid, mucocele, central mass. It could be bullous disease. It could be compensatory hyperinflation. Maybe just like in the congenital lobar syndromes, you have a small right lung, so the left lung is going to be hyperinflated. It could be congenital lobar emphysema. That would cause a hyperlucent lung, which is increased. A congenital diaphragmatic hernia. This was my son. He was doing great. He was 6 months old. I was at the AFIP, now AIRP, and they came to visit me. And the next day, the second day they were there, the first true day they were there, I came home from the AFIP, and my wife said, "Ryan's throwing up. It's kind of yellow." And I looked, and it was. And he looked fine. He didn't look dehydrated. He wasn't breathing funny. So we gave him Pedialyte, and he kept on throwing up. So then I called Dr. Rosanna de Christensen. I don't know if she's still there doing pulmonary. She might not be there, but she was there. She was Air Force because I was Air Force. So I talked to her. She gave me the number to her pediatrician. He said, "It sounds like a virus, a gastroenteritis." I said, "This is bile he's throwing up." And they said, "Well, they can do that." So they said, "Don't feed him, and then in the morning, give him Pedialyte. If he still throws up, come see me." So the next morning, he threw up the Pedialyte, bilious, still played, looked good. So we took him to the Holy Cross, which is a private hospital there in DC. And I took my oldest son home to take a nap, and I came back. I said, "Where's Ryan?" And my wife said, "They took an x-ray of him, and they said my hands were in the way," which is a lie. But I said, "Crap, that doesn't make sense." So I went down there, and this is what I saw. This looks like the hemidiaphragm with shift of the cardiothomic silhouette to the right, but this is bowel. This is bowel up in his chest. This is a boctulate hernia. And when this is the post-op, his hemidiaphragm returned to normal. Normally, a boctulate hernia is going to present in utero. If those babies aren't at a high, very specialized institution that can do in utero surgery, the babies usually are going to die because the bowel is going to go into the left lung. So the left lung is not going to form. The heart and mediastinum are going to get shifted over to the right, so the right lung is not going to form. So when these babies are born, if you pull the bowel back into the abdomen and close the hole, they still have hypoplastic lungs. They're going to die. Luckily, thank goodness, thank God, my son didn't have it, and the surgeon thinks at Children's Hospital thinks that there was a size of about a nickel or a quarter, a hole, and he thinks the spleen was blocking it in utero and during the first 6 months, 6 weeks of life. And that, you know how when you get on an airplane, your ears pop? Because it's not controlled atmosphere down here. It's controlled to a certain level of atmosphere, but your ears pop. And they think that allowed the spleen to move. The small bowel went up into his chest, and that's why he had it. So this is what he looked like pre-op, and here he's back to normal, and now he's finishing his first year of med school in Galveston. Normal, no pulmonary abnormalities. But what you have to worry about is they can be associated with other anomalies, and so you just got to hope that that's not the case. This is absent closure of the pleural peritoneal fold by the 9th week of gestation. 1 to 2,200, 1 to 3,000 live births. Male more than female, 2 to 1. My son's a male, so just remember male more than female. Associated anomalies, if the baby is born alive, only 20% will have anomalies. So my son was in the 80%, thank goodness. If they're stillborn, 90% are going to have anomalies, especially a neural tube defect in 28%, a GI abnormality in 20%, especially malrotation, omphalocele, and cleft lip. Cardiovascular in up to 25%, GU 15%, chromosomal abnormalities in 4%, especially Edwards and Down syndrome. Boctulate hernia is by far the most common. It's going to be on the left and the back. If you can't remember back, just remember Bach. Sounds like I get in the back of me, in the back of me, in the back of me. Boctulate is in the back, the posterior lateral part of the left side in 80%. Morgagni hernia is not that common. It's usually on the right anteromedially, and maybe the liver or fat herniates into the chest. Eventration is kind of, you could say, is this a diaphragmatic hernia or is this eventration? Eventration, 5% usually anteromedially on the right. If it's on the left, usually the entire left hemidiaphragm is elevated, and eventration is much more common on the right than the left. Other conditions that we see in peds all the time, aspirated swallowed objects, they put everything in their mouth. A pneumothorax, trauma, child abuse, near drowning, sickle cell disease, cystic fibrosis. On an aspirated foreign body, there's two things that you can get if they aspirate. You can get this totally obstructing the bronchus, and they're going to get complete collapse of the left lung. You come over here and you always look for a radiopaque foreign body. But here you don't see a radiopaque foreign body, but the main stem bronchus kind of stops, and then you have total opacification of the left pneumothorax with total shift of the cardiomyosine sweat to the left and hyperinflation of the right lung. This tells you there's left lung atelectasis. You have to worry there's an interbronchial mucus plug. maybe the patient's wheezing and they know that they had something in their mouth. They scoped this, bronchoscopy this here. They did a CT first. Didn't need to, but they did. You can see the right main stem, left main stem, and then it just stops. And I think it was an aspirated, maybe a cashew, aspirated peanut, cashew. They're non-radiopake, you can't see it. The other thing that you can get is, oh, this was the aspirated cashew, so the other one was some aspirated foreign body. You can get a ball valve mechanism. It gets in the main bronchus and it lets air in, but it doesn't let air out when they breathe, and so they get a hyperinflated, lucent lung, and so it can shift away from it, and you can see how lucent this lung is compared to this lung. And this was air trapping from an aspirated foreign body, and it was a cashew. Here, this is most likely is going to be a coin, but it could be a battery. And you got to realize a lot of people think that's as big like a quarter, but a lot of these times they're just pennies because there's magnification. So you really can't tell what coin this is. But here we know this is not in the trachea because here's the tracheal air column. This is, if it was in the trachea, it should have been in the trachea, the whole thing, but this is not. This is outside the trachea. But they always do a lateral view, and it doesn't hurt to do a lateral view because here there's 1, 2, 3, 4. Now the gastroenterologist, the surgeon, or whoever, ENT, knows that there's 1, 2, 3, there's 4 of these round disc-like, coin-like objects in the thoracic inlet. Chances are, okay, the kid swallows this. The mother notices that the kid swallowed it. They bring the kid to the hospital. They get checked in. The nurse orders an x-ray. They go get an x-ray. And by the time all that happens, if it's here, the chances of it passing are pretty slim. It's probably not going to pass. If it's in the chest, it's probably not. I've seen a couple that did pass, but most of the time, if it's here, if it's lodged at the thoracic inlet or the aortic arch or at the GE junction, those are the 3 spots they'll get caught. They're probably going to have to go in there and get them because you have to get it because they'll cause pressure necrosis. They can perforate the esophagus. They can cause scarring and strictures. But here, the good thing for the gastroenterologist is when he goes and scopes them and removes this, he gets a tip. He can use it, that's the tip. So he's hoping they're quarters, but a lot of times they're not. But if they can be batteries, and that was not good. The worst thing to swallow nowadays, well, everything is bad to swallow, but you sure don't want to swallow magnets. If they swallow magnets, they can get in different parts of the small bowel, and they can attract and cause pressure necrosis, perforation, and the kid could die from it, get septic and die from peritonitis. A pneumothorax is a pneumothorax is a pneumothorax. This is a brand new baby. If you have a brand new baby who's just born, 0 days old, and you see bilateral pneumothoraces, you have to really worry that they had oligohydramnios in utero. There's probably something wrong with the kidneys because the lungs didn't form. This is lung hyper. What's the word? Hypoplasia. Hypoplastic lungs can present with bilateral pneumothoraces, and this baby did have either a bladder outlet obstruction or multisystem dysplastic kidneys. So bilateral pneumothoraces. There's the deep sulcus sign. You know, if you see a deep sulcus sign, that tells you there's a pneumothorax. If you ever have a chest x-ray and you see subcutaneous emphysema and it was trauma, but there's no penetrating injury, there was no chest tube in it, but you see subcutaneous emphysema, you have to really worry there's a pneumothorax or a tracheal injury or esophageal injury. But if you don't see a pneumomediastinum and you don't see a pneumothorax, but you see subcutaneous emphysema and there's no penetrating injury, you have to really be concerned that there is a pneumothorax present that you just can't see. But usually they'll go to CT and you'll find it. Here is a tension pneumothorax. This is a hyperlucent, hyperexpanded left hemithorax compared to the right. This is the collapsed right lung. This is an emergency, a second intercostal space. They need to put a needle in there in the midclavicular level and then put a chest tube in. These babies can get poor venous return back to the heart, and they can, adult or child can die. Trauma. This, if you see this little, it looks like a little spring-like object. This is an ECMO device, an ECMO. Here we have subcutaneous emphysema. We have streaky black around the heart and the mediastinum. This is pneumomediastinum with subcutaneous emphysema. You can also get pneumomediastinum and subcutaneous emphysema with significant asthma. An asthmatic can present with pneumomediastinum just because of the severe wheezing and the asthma that he or she had. Child abuse is terribly common, and they did this study locations of fractures from 31 children who died. The most common were rib fractures. You know, for child abuse, the suspicious rib fractures are the posterior rib fractures. Also suspicious are continuous lateral rib fractures. When you grab the kid and you squeeze the kid's chest, you can get lateral contiguous rib fractures bilaterally. The hallmark for child abuse is the metaphyseal corner fracture. The most common place for metaphyseal corner fractures are around the knee and around the ankle. Those are the most common places for the metaphyseal corner fracture. Long bone fractures are very common, but they're not specific. If it's a 2-month-old and they have a femur fracture, that takes a lot of explaining. How did that 2-month-old that doesn't move, how did they get a femur fracture or a humeral fracture? But if they're like a 14-month-old or 15-month-old and they're a toddler, they can get fractures, but the metaphyseal corner fractures are what you really look for. The posterior rib fractures, you look for those. Skull fractures, a loving, caring mother or father can drop their child or can have the child roll off a couch. And if they have a hard floor, they'll get a skull fracture. So skull fractures are suspicious, but they're not diagnostic at all for child abuse. They're not uncommon. We do a lot of bone surveys and there's a skull fracture, but there's nothing else. So that's not the highly specific ones. This was an abused child. The most commonly broken bone of the body is the clavicle. This is a clavicle fracture that's healing, but don't even worry about that because that doesn't mean diddly. What does mean diddly are these healing fractures out here, multiple healing fractures in a row on both sides. Posterior acute rib fractures, there's no periosteal reaction. Here there is in callus. Here, posterior rib fractures, here's a posterior rib fracture, and there's a metaphyseal corner fracture. This is multiple fractures at different stages of healing. That's very suspicious for child abuse, and it is our responsibility to tell the pediatrician that we suspect child abuse. We don't put that in our report. We dictate non-accidental trauma. At our institution, they put SCAN, which stands for Suspected Child Abuse and Neglect, but the patients don't know what SCAN means. But you could say this is highly suspicious of non-accidental trauma. When I go to court to testify, the first time I went, I said this is consistent with child abuse, and the judge went, I object, don't say that, don't say that. He didn't object because he was a judge, but he said, Dr. Gates, don't say that. I said, okay, this is consistent with non-accidental trauma, and he said, thank you. Child abuse is an accusing, and we just know that the baby's being abused by somebody. We don't know who. So it's scary to go, but these are the acute fractures. These are the healing fractures. Here's later on, there's more callus, more healing. There's still that fracture, still the fractures here. Rib fractures and CPR. The lawyers, when you go to testify, are going to try to tell you that the baby has rickets, that the baby has osteogenesis imperfecta, or that they had CPR because the baby wasn't breathing. Posterior rib fractures cannot be reproduced. They did a study, they could not reproduce posterior rib fractures. Children are pretty pliable, so when you do CPR on a kid, rib fractures are not that common. They're a lot more common in older people than they are young, little infants and newborns. Posterior compression is not a feature of CPR, and they did the studies and they could not reproduce a posterior rib fracture with CPR. So if you see a posterior rib fracture, you can say they've done studies and they cannot reproduce it. Near drowning, what near drowning looks like is bilateral alveolar consolidations. This is alveolar. They look like clouds, they're fluffy, they have air bronchograms. There's no way that without a history you could say this is near drowning. This looks like pulmonary edema. This could be bilateral pneumonia. This could be bilateral hemorrhage. This could be smoke inhalation injury. This could be near drowning. If there's an older person, it could be amyloidosis, alveolar proteinosis. This just means that the alveoli are filled with something. They're filled with fluid, pus, cells, something. But this was what near drowning would look like. And of course, if you drown, you want to drown in freezing water because you can live longer. You can be underwater longer in freezing water than you can in warm water. And the thing that causes the chemical pneumonitis is what's in the water. It's not the water itself, it's what's in the water. If you're in clean water, you're less likely to have any long-term effects unless you were really hypoxic and then neurologic effects. But I'm talking about for your lungs. If it's pretty clean water, if it's drilled filthy water and there's all kinds of chemicals and bacteria in there, you're going to have bad lungs afterwards. But this is what rip-roaring fluid overload could do. You gave too much fluid. This could be neurogenic pulmonary edema. I gave you bad head trauma and now you're going to neurogenic pulmonary edema. So that's why clinicians don't like radiologists when we say clinical correlation is recommended. because they don't give us a history. They have to give us a history. If the kid's got a fever and a cough, that's pneumonia. If they gave him too much fluid, that's pulmonary edema. You know, if he's got lupus, he's probably got pulmonary edema and he could have a pericardial effusion. Realize that, residents realize that when you say there are bilateral infiltrates, the clinician is thinking pneumonia. You say the word infiltrate, they think pneumonia. We know that infiltrate is anything that infiltrates. Hemorrhages infiltrates, tumors are infiltrates, pneumonia is infiltrates, pulmonary edema is an infiltrate. But you say infiltrate, the clinician immediately thinks pneumonia. Sickle cell disease, very, 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 very common. It's a horrible disease. It's a lifelong disease. They're living a lot longer than they used to. What you classically see, you see an enlarged cardiac silhouette, a big heart, big pulmonary vessels because they're anemic. Anytime anyone's anemic, the heart's just going to pump away because they're anemic. They're going to develop alveolar consolidations. It could be infectious or it could just be from the chest syndrome and the infarcts. What they'll do is they'll give them fluid. They might have to transfuse them. They'll give them antibiotics. And a lot of times they're going to come in with a chest syndrome. It's going to be normal. And then the next day they're going to repeat it. And you're going to see this big alveolar consolidation and then pleural effusions. You look for the vertebral implate changes. The fish mouth vertebrae, or almost looks like a little Lincoln log. If you guys know what a Lincoln log is, it's a toy we used to play with, build forts and houses and stuff. They're really cool. Always look over here. Don't forget to look the spleen. Look for a big spleen. If you see the stomach gas way over here medially, and if you have more of an abdomen and you see the hepatic flexure and the hepatic flexure is as high or higher than the splenic flexure, maybe there's a big spleen. You need to let them know that. On the lateral view, that's always good to see the little posterior lung base consolidations early because you can miss it on the frontal view. Look for the vertebral implate changes. Sometimes that'll be the best view you can get it on, but you can see it on the frontal view as well. This patient has a big left ventricle, is touching the spine. Sickle cell, terrible thing, terrible disease. Cystic fibrosis is another terrible disease. We used to have the Bettina Hillman house up here because she was a pulmonologist, pediatric pulmonologist when I was a resident and medical student. But what you look for is cystic fibrosis. They're going to get bronchiectasis, and it's usually an interstitial lung disease worse in the upper lung fields. That's the differential for interstitial lung disease in the upper lobes as opposed to the lower lobes. Here you have bronchiectasis. You have big pulmonary arteries. These pulmonary hyla are big because they get pulmonary arterial hypertension. Anytime you have chronic interstitial lung disease, you're going to get pulmonary arterial hypertension. They can also get adenopathy from recurrent pneumonias. There's another bronchiectasis here. So what you want to look for, the lungs are going to look nasty. You just want to look, are there new opacities? Are there cylindrical looking opacities that can be mucus plugging? Are there more whiteness up in here that could be a superimposed pneumonia? Here is another patient with cystic fibrosis that often have a portacath. In CT, you know that with the artery is the little white dot, and the bronchus is the ring with the black in the center of it. This is the I'm drawing a blank. Signet ring, or it looks like a pearl ring. You have your ring and the little pearl on it. That's bronchiectasis. The bronchi should be the same size and not bigger than the adjacent pulmonary artery. So this is bronchiectasis here, cystic bronchiectasis. Cystic fibrosis, autosomal recessive, almost always in Caucasians, but they can be seen in patients of mixed descendant. They do the sweat test, which will show increased sodium and chloride. They get recurrent pneumonias, mucus plugging. We told about upper lobe predominance. They get pulmonary arterial hypertension. It's associated with Meconium ileus. So if you have a newborn, a brand new baby was born, and they do an KUB, and you see free air, you see calcifications all over the peritoneum, you might see ascites, that's meconium peritonitis. That means in utero, the baby perforated the small bowel, and it could be due to Meconium ileus. Meconium ileus is when the meconium gets so thick it blocks the ileocecal valve, and so you cause a small bowel obstruction and the small bowel perforates. Meconium goes in the peritoneum, it causes the peritonitis, and Meconium ileus is associated with cystic fibrosis. It could be due to jejunal atresia, ileal atresia, but if you have Meconium ileus, they could have cystic fibrosis. Cystic fibrosis is associated with pancreatic insufficiency. It can cause pancreatitis. The most common cause of pancreatitis in a child is blunt trauma. then it would be cystic fibrosis. They can get gallstones, they can get focal biliary cirrhosis. They have increased incidence of getting sinusitis and hypoplastic frontal sinuses. Infections, you can get osteomyelitis of your chest, bacterial pneumonia, viral pneumonia, you can get TB. So let's start with osteomyelitis. Here was a permeative lesion in the clavicle. You would worry, okay, could that be infectious? Could that be a Ewing sarcoma? Ewing sarcoma can affect flat bones. Ewing sarcoma usually affects cylindrical bones in younger children and flat bones in older children and young adults. But this could have been a Ewing sarcoma. There's thickening here of the cortex. There's a permeative appearance here. They did a CT and you can see this moth-eaten permeative pattern. They did an MRI and there's a big extra soft tissue component. This was a fungal infection on a patient. Osteomyelitis. Bacterial pneumonia, classic bacterial pneumonias are going to be lobar. Behind the heart, you don't see the normal vessels. There is a left lower lobe pneumonia. You'd like to have a lateral view because it should get blacker as it goes down, and instead it gets whiter here. This is the left lower lobe pneumonia, and this is classic for bacterial pneumonia. Viral pneumonias, on the other hand, okay, here's a round pneumonia. Round pneumonia are more common in children than they are in adults, but this is a round pneumonia. That's usually bacterial. And viral are usually interstitial and parabronchial cuffing and interstitial. This can look like a atypical pneumonia. This is a viral pneumonia. This could be interstitial edema, but this is classic for viral pneumonia. Later on, they can get alveolar processes, but initially it's usually interstitial with parabronchial cuffing. Tuberculosis. This is not a child, but this is there's a TB cavity with all this pleuroparenchymal scarring, retraction of the trachea to the right. This is old. The hilum is pulled up. There's a Shreveport granuloma. We have so many patients with bullets. It's amazing. I was in the military, didn't see this many bullets in my life in the 7 years in the military, and so many patients, including kids, have bullets, and that's not why they're here, because they got shot a while back. This was TB. Tuberculosis. The Ghone lesion is the granuloma. The Ghone complex or the Ranke complex is when you have the Ghone lesion and the calcified hilar or mediastinal lymph node. So you have the Ghone lesion, which is just the granuloma that's calcified. The Ghone complex or the Ranke complex is when you have the Ghone lesion, the granuloma, and the calcified lymph nodes. Be careful. A lot of residents dictate when they do a chest x-ray, it doesn't matter on adult or child, but they'll see hilar adenopathy that's calcified, and there's no granulomas in the lungs, and they'll say impression old granulomatous disease. That's really not a good thing to say. You should say calcified hilar adenopathy, because you could have had treated lymphoma. You could have had silicosis. For old granulomatous disease, you should see a granuloma plus the calcified hilar lymph node. So there could be a tumor that was calcified, a treated tumor that calcified, and it's not from old granulomatous disease. Primary TB is classically a disease of children and usually asymptomatic, but it has increased in adults. If there are clinical symptoms, the chest x-ray on a kid, you can have a unilateral airspace opacity with hilar adenopathy. Adults usually don't get adenopathy with TB. Children sure can. It can also present with a pleural effusion, and that might be all you have is a pleural effusion. So theoretically, if they say positive PPD and all they had is a pleural effusion, that could be active TB. It can have pleural effusion with or without parenchymal findings as the presenting chest x-ray finding. Cavitation is not common in primary TB except in the infant. It can affect any lobe, and it may have a right-sided predominance, as opposed to reactivation TB, which it develops usually in the upper lobes, especially the apical segments and the posterior segments, due to the high PO2 concentration and the VQ ratios. The airway, what time is it? 10 till. Here is a child, and they put this NG tube down, it just loops up here and it stops right here, and they pulled it out, they put it back in, it keeps looping and looping and stopping right here. That's very worrisome for a TE fistula. The most common type of TE fistula by far is this one. When the upper esophagus ends blindly and the lower esophagus is attached to the distal trachea, that's by far the most common. The second most common is when the esophagus is just atretic in the middle, there's no communication. So this would be a gasless abdomen. This would have gas in the abdomen, this would be a gasless abdomen. So these are the two most common. So if you put the NG tube in and it doesn't go into the stomach, you could have a TE fistula, because these are by far the most common. The third most common is the H type. This one you would be able to put an NG tube down and get it in the stomach. This one would have gas in the air, in the stomach, in the abdomen. This one right here, this type is rare. It would not have, it would have a gasless abdomen. This type would have gas in the abdomen because of the tracheal connection. Tracheobronchial anomalies. Tracheomalacia is due to tracheal wall softening due to abnormality of the cartilaginous rings and hypotonia of the myeloelastic elements. There are two types, both are rare. Primary is congenital immaturity of the cartilage, and secondary, which is degeneration of the normal cartilage. The congenital type may be associated with other defects such as vascular rings or a TE fistula. It commonly involves most of the trachea and other major airways. Tracheomalacia, all infants have some normal degree of airway collapse during expiration. So when they're expiring, the airway will collapse a little bit, but in tracheomalacia there is total obstruction with expiration. They can present with wheezing, cough, stridor, dyspnea, tachypnea, cyanosis, recurrent respiratory infections. The congenital form will improve usually by 6 to 12 months of age because they're going to get bigger. The bigger they get, the bigger the trachea gets, the less stenosis there will be. You can do fluoroscopy to evaluate with inspiratory and expiration to see if it's getting smaller. You can do esophagography, maybe diagnostic showing exaggerated decreased caliber in the trachea during expiration. Some people will do CT and cross-sectional evaluation. Here is an example. Here is a narrowed trachea. It's very narrow. That's tracheomalacia. Of course, you don't want an esophagram. You want to look for posterior impressions on the esophagus from an aberrant subclavian artery. You want to look for an anterior impression on the esophagus between the trachea and the esophagus from a pulmonary sling. The most common cause of a pulmonary sling is the left pulmonary artery coming from the right pulmonary artery. So the left pulmonary artery originates from the right pulmonary artery, then goes between the esophagus and the trachea to go to the left, and that can cause an impression on the esophagus and the back of the trachea. Congenital tracheal stenosis is a rare disorder characterized by the presence of focal or diffuse complete tracheal cartilage rings resulting in fixed tracheal narrowing. May be seen with other anomalies such as pulmonary artery sling. Usually half of them are focal, just a short segment. They can be generalized or they can be funnel shaped. The focal type consists of a simple local narrowing of the trachea, usually in the distal third. Symptoms vary depending on the age and the degree of stenosis. It doesn't necessarily depend on the length of the stenosis. It depends more on the degree of the stenosis. 90% present during the first year of life, usually with a biphasic stridor. The length of stenosis is not as critical as the degree of stenosis. You can do AP and lateral radiographs using soft tissue technique, or barium esophagram can aid in the diagnosis, or some people do CT. But here you see an area of narrowing here, and there's an area of narrowing here that's persistent. That's an area of tracheal stenosis. It's a short segment, even though normally they're in the distal part. Here, there are two areas of narrowing right here and right here. What time is it? 5 minutes till. A tracheal bronchus includes a variety of bronchial anomalies arising from the trachea or main bronchus and directed toward the upper lobe territory. It's usually on the right. It usually exits the right lateral wall of the trachea less than 2 centimeters above the carina. Left tracheal bronchus is less prevalent. It's termed displaced, which is the most common, or supernumerary, depending on the anatomy. So if you have if the anatomic upper lobe bronchus is missing from the main bronchus, and you have a single branch that's coming from the trachea, that's called a displaced bronchus. If the upper lobe bronchus has normal trifurcation of the apical, posterior, and anterior segment, and you still have another bronchus going to it from the trachea, that's called a supernumerary bronchus. If the supernumerary bronchus ends blindly, it's called a diverticula. If the supernumerary bronchus ends in aerated or bronchiectatic lung tissue, it's called an apical accessory lung or a tracheal lobe. It's usually asymptomatic but may present with persistent recurrent upper lobe pneumonias, atelectasis, or air trapping and chronic bronchitis. Bronchiectasis, focal emphysema, and cystic lung malformations may coexist. It's associated with the infantile lobar emphysema, unknown but frequently seen with left tracheal bronchus. So if you have a left-sided one, you might have a lobar emphysema. The diagnosis can be made with CT. Most can be treated with conservative management, but if there's a symptomatic thing, they just go in there and they just take it out. And here is a CT showing the trachea, and there's a bronchus coming up to the right upper lobe. So if you went down to the right mainstem bronchus and it gives way to the upper and then the bronchus intermedius, and that goes the apical and all, and the 3 different segments, this is a replaced. No, this would be supernumerary. If there are no vessels going to the upper lobe, from the main pulmonary artery. Then that would be a replaced bronchus. Here is a bronchogram that used to do bronchograms. That's why when we do swallowing studies to look for aspiration, we use a thin barium because they used to do bronchograms. And here you have a tracheal bronchus right here. And I'll stop at that since it's almost 1. Anyone have any questions? For us, I'll finish this talk next time. New Orleans, thank you very much. I hope that this was helpful. I'll see some of y'all next week at the AUR. Good luck, and the third years, good luck with y'all's tests.